Thank you, Chairman. Good morning, ladies and gentlemen. My topic is there any tooth sick patient for living donor transplant? So what is tooth sick? It means a high risk recipient, and it resulted it's related with high mortality during waiting list, and high mortality is expected after transplantation. So it can be considered as contraindication of liver transplantation. But the question is, we can use the same criteria or a definition of tooth sick in the living donor transplant. So as the number of risk factors are increasing, expected mortality after transplantation can be increased as shown in this graph. But the acceptable mortality rate in diseased donor liver transplantation is a minimum 50%. But it can be extended in living donor liver transplantation because living graft is a dedicated gift to only one recipient. Therefore, in my opinion, to do or not to do living donor liver transplantation can be decided by case by case. So when we decide the living donor transplantation, we have to consider condition of the recipient, quality of living graft, and center experience as well. Because living graft is a small volume, usually small for size graft, and we have to consider the quality of parenchyma and the inflow and outflow of the graft. And center experience is more important, so the anesthesia management and surgical technique, teamwork, and sophisticated postoperative management protocol is very important. So we have to consider these all factors to decide living donor transplantation. But in this talk, I would like to focus on more condition of the recipient. So there are several potential tooth sick recipient conditions: acute fulminant liver failure, high MELD score, hepatopulmonary syndrome, portopulmonary hypertension, or infectious or septic conditions. So I would like to present in each conditions. Let me start with acute liver failure. Acute liver failure is rapidly progressive, life-threatening condition. It is defined by massive liver injury-induced severe hepatic dysfunction, such as coagulopathy, hepatic encephalopathy within days or weeks. It commonly combined with inflammation, sepsis, and multi-organ failure. So there are several models for selection of a liver transplant candidate in acute liver failure. King's College criteria is a very famous one, but it's not enough yet. But furthermore, there is no object criteria of a contraindication of liver transplantation. So one report from Korea, they reported risk factors for 1-year mortality after transplantation in acute liver failure. The old recipient age, renal dysfunction, hyponatremia, and the vas pressure, and old donor age were significant risk factors. The 1-year mortality reached up around 80% if all risk factors present. And they said there is no difference in terms of survival between DDLT and LDLT. But this slide summarizes the risk factors in the literature after liver transplant for ALF. In recipient condition, recipient age, renal dysfunction, vascular requirement, hyponatremia, superimposed infection were significant risk factors. And in terms of donor side, donor age, statosis, small side graft, and AV incompatibility were significant risk factors. So irreversible brain injury, brain death, is a main concern. It's a major, very grave morbidity and one of the important reasons for mortality after transplantation in this situation. So there are not so many reports regarding the risk factors for brain injury after transplantation. So one report from UCLA, they said that the severe cerebral edema on preoperative brain CT scan or preoperative seizure history and extended donor graft were significant risk factors for brain injury. However, when we look at this data, and in my personal experience as well, the seizure itself cannot be absolute sign, the objective sign to exclude the liver transplantation. This 4.8% who showed preoperative seizures here was recovered without any problem. So in summary, to seek for liver transplantation in this setting will be evidence of irreversible brainstem dysfunction and fixed dilated pupils, refractory escalating vasopressor requirement or hypoxemia. Systemic sepsis was refractory deteriorating clinical status despite of antimicrobial therapy. So let's move to the high MELD score. You know, the MELD score composed of total bilirubin, INR, and creatinine. So it validated it is validated good predictor for waiting list mortality. However, in terms of post-liver transplant survival, there are some debates. But a recent paper showed that there is no difference between high MELD and low MELD score, even in living donor transplantation. So I can say that a high MELD score itself is not a contraindication of a living donor liver transplant. Let me show you my case. It's a 45 years male patient who has alcoholic liver cirrhosis, hepatorenal syndrome, and CRRT, but he was septic shock, and he was on norepinephrine, is high norepinephrine, but the antibiotic was started for the 7 days before transplant. So we decided to do a living donor transplantation. But there was a severe peritonitis, and the small bowel and colon showed ischemic changes. So he was died postoperative 50 days because of septic shock, sustained septic shock. So the high MELD score, but if it is combined with sepsis, can be ongoing sepsis, it can be a contraindication of a living donor situation. The donor factor as well is important as well in high MELD situations. So the significance of a donor D-MELD score, donor age multiplied by MELD score, were reported by this person in 2009, and a similar report was reported by Dr. Ikigami this year. So Professor Gang presented in the primary session about hepatopulmonary syndrome and portopulmonary hypertension. Briefly, hepatopulmonary syndrome, especially in severe and very severe situation, high morbidity and mortality in the waiting list. Therefore, the United States, in this condition, room PaO2 less than 60 millimeter mercury, the MELD expression point, 22 points were added in MELD score. So in terms of mortality after transplantation, yes, there is a very significant risk factors in severe or very severe situation. However, the recent paper reported that a very favorable post-mortality outcome even in severe and very severe hepatopulmonary syndrome. It may be related with accumulating experience and standardized post-operative care protocol. So the now accepted relative contraindication is significant cardiopulmonary disease and end-stage renal disease in very severe hepatopulmonary syndrome. So this is my case. This 20-year female young lady has a very severe hypoxemia, and the brain lung scan showed 50% of shunt fraction. So she is not LDLT case. She received a deceased donor, very young male deceased donor graft. Luckily, she could get this liver, and she can be extubated 1 day after transplant. But even though she needs home oxygen therapy for 6 months, but her symptom and everything became normalized 1 year after transplantation. So now we can say the favorable post-liver transplant outcome, even in severe and very severe HPS nowadays. So portal pulmonary hypertension is already mentioned that, but nowadays, again, the perioperative vasoactive therapy increases survival, even in moderate to severe portal hypertension. So the septic condition, the most common infection in cirrhotic patient is SBP, followed by UTI and pneumonia. So active infection, as you know, is usually contraindication of liver transplantation. But there are several reports to show that appropriately treated preoperative infection is not a significant risk factor. So this is summarized slide. Is there any tooth sick in LDLT? Maybe yes or not, but the fulminant hepatic failure, irreversible brain damage, even though we cannot assess exactly which is irreversible brain damage, but anyway, irreversible brain damage or combined sepsis, severe sepsis, should be excluded in living donor transplant. In high MERD situation, patient, if the patient combined with severe sepsis, it can be ruled out transplantation. Hepatopulmonary syndrome, very severe hepatopulmonary syndrome combined with cardiopulmonary disease or end-stage renal disease, we can consider too sick for living donor transplantation. Portal pulmonary hypertension, vasoactive therapy, non-responders should be we have to consider some exclusion. So in infectious or septic condition, active or uncontrolled infection or sepsis on the inotropic, we have to consider too sick condition, recipient condition for living donor transplantation. But again, living donor graft quality, center experience, and donor or family's willing are also very important to define too sick. Thank you for your attention.